Bismillahirrahmanirrahim. So the next topic in nephrotic syndrome is membranoproliferative glomerulonephritis. Membranoproliferative glomerulonephritis is an immune-mediated disease which results in the proliferation of glomerular basement membrane and endothelial cells. The disease is actually derived by the recruitment of the inflammatory cells such as macrophages and neutrophils that cause the inflammation and proteinuria. Membranoproliferative glomerulonephritis can be of two types, which is type 1 MPGN and then there is type 2 MPGN. Type 1 could be either primary, which means this is an idiopathic disease with the cause lying within the kidneys, or it could be secondary, which means there is a systemic disease that is resulting in the inflammation in the kidneys, such as systemic lupus erythematosus, hepatitis B virus infections, or hepatitis C virus infections. Type 2 membranoproliferative glomerulonephritis is also known as dense deposit disease, and it is basically derived by the C3 complement system. So type 1 and type 2 MPGN are more or less similar in the morphology, but they differ in their pathogenesis. So type 1 membranoproliferative glomerulonephritis is a classical disease which is derived by the IgG or occasionally IgM antibodies. So there are proteins which are derived from the infection such as hepatitis B virus or hepatitis C virus. So these proteins act as antigens which activate the IgG and complement system, resulting in immune complex formations. So these antigens are either separately deposited in the glomeruli or preformed immune complexes are deposited in the glomeruli which recruit the inflammatory cells such as neutrophils, macrophages and monocytes and cause inflammation. The inflammation damages the glomeruli and glomerular basement membrane, resulting in proteinuria. So in type 2 membranoproliferative glomerulonephritis, there is complete absence of IgG or IgM antibodies. Rather, there is an activation of C3 complement system which is deposited in the glomeruli and mesangium. The C3 complement in type 2 membranoproliferative glomerulonephritis is resistant to the inactivation and hence recruits the inflammatory cells to the glomeruli, resulting in glomerulonephritis. So membranoproliferative glomerulonephritis appears as large hypercellular glomeruli in the histology, which give a lobular appearance. As you can see here, this is the glomerulus. It is enlarged, lobular and hypercellular. The hypercellularity is due to proliferation of endothelium and mesangium. Moreover, there is increased infiltration of inflammatory cells which add on to the cellularity of glomeruli. The classical differentiating feature of membranoproliferative glomerulonephritis is a thickened GBM giving a tram track appearance. So this is a glomerular basement membrane and these are the inflammatory cells or endothelial cells. So what happens in this case is a new glomerular basement membrane is laid down with the cells trapped within these glomerular basement membrane. So this gives a typical tram track appearance to the glomerular basement membrane. As you can see here, the glomerular basement membrane gives a double contour and there are cells as well entrapped between these double membranes. The cells could be either inflammatory cells, they could be mesangial cells or endothelial cells. The electron microscopy reveals dense deposits in the mesangium, endothelium and subepithelium. Type 1 and type 2 diseases differ from each other in a way that there is permeation of lamina densa of glomerular basement membrane due to a deposition of an unknown electron dense material in type 2 disease. Moreover, on immunofluorescence microscopy, there is granular deposition of immune complexes. The disease typically presents in the young adults and the signs and symptoms are of nephrotic syndrome. One thing to remember is that the proteinuria could be mild, often falling in the range of nephritic syndrome, whereas hematuria can also be present. The definite diagnosis is on histopathology of the biopsy, and steroids are of minimal use in this case. Prognosis of type 2 disease is poor, which is also known as dense deposit disease, and renal transplant in the end stage disease can also be needed. A 17-year-old male with edema and hematuria presents in clinic. Diagnosis of nephrotic syndrome due to membranoproliferative glomerulonephritis is made. What is a typical feature on histopathology? So the typical feature on histopathology is the tram track appearance, which is a double glomerular basement membrane with the entrapped cells giving a tram track appearance. So what is the difference between type 1 and type 2 membranoproliferative glomerulonephritis pathogenesis? The main difference is that in type 1 disease, there is IgG or in rare cases IgM antibodies. Whereas in type 2 membranoproliferative glomerulonephritis, the disease is driven by the C3 complement. So what is the immune complex deposition pattern on immunofluorescence microscopy? The immune complex deposition is in granular fashion. So this brings us to the end of the discussion. If you have any questions, let us know in the comments. Thank you.